I'm Terry Young. I'm the chair of the UW Department of Ophthalmology and Visual Sciences, and I welcome you here this evening for our third Saving Sight session. These are community medical education programs, and I'm just delighted that you're here. Thank you so much for coming. I'm wearing red today because it was a Chancellor's Luncheon and an Alumni Day, and I had no red on earlier, and I'm feeling not so patriotic, so I thought I would put this on for a little punch. I have the distinct pleasure of introducing our speaker tonight, who's a colleague of mine. This Saving Sight session is entitled Eye, Ears, and Aging, and I will introduce our speaker, Karen Cruickshanks. Karen is a professor of the Department of Ophthalmology and Visual Sciences, as well as a professor of the Population Health Sciences Department here at the university. She received her bachelor's in biology at the Wesleyan University in Connecticut and her PhD in epidemiology at the University of Pittsburgh in Pennsylvania. She's been here since 1990, so a 26-year record, and her accomplishments are many. These are just a few. Distinguished Alumni Award for Research at the University of Pittsburgh School of Public Health, the Merit Award at the National Institute of Aging at the National Institutes of Health. She's the Alice R. McPherson Retina Research Foundation Chair in Ophthalmology here at UW-Madison Medical School. She's received the Lou R. Wasserman Merit Award from the prestigious Research Department Blindness Incorporated. She's a reviewer of 20 different journals and magazines, has almost 200 publications in peer-reviewed journals, 200 abstracts, invited presentations, book reviews, and 9 written book chapters, and 29 years of teaching experience. Karen's going to talk to us about her work in the epidemiology of hearing loss study and the Beaver Dam offspring study, both ongoing longitudinal cohort studies conducted in Beaver Dam, Wisconsin. Let's see, I'm having a little bit of trouble. The BOSS participants are the adult offspring of the epidemiology of hearing loss study. Findings from these studies are used to determine possible risk factors and interventions for age-related sensory disorders and to help predict future healthcare needs in the United States. So examining these multiple senses and numerous aspects of health in families and multiple generations allows for a more integrated, complete view of sensory health and sensory decline with aging. These community partnerships with these epidemiologic type studies, like the Beaver Dam, Wisconsin, with EHLS and BOSS, will continue to provide much needed data to improve the likelihood of healthy aging. And we're very pleased to have Karen present this. Her work has been instrumental in directing public policy and public health initiatives. I also just wanted to let you know about our next Saving Sight session, which will be April 20th, 2017. This will be presented by Dr. David Gamm, another member of our Department of Ophthalmology and Visual Sciences, who will speak on balancing hope and hype, the potential of stem cells to help patients with blinding diseases. Karen, take it away.
Well, thank you very much for that introduction, Terry, although you made me think that maybe the reason I'm speaking about aging is because of how long I've been here. I was in much better shape when I arrived. So today I'm going to be talking about eyes, ears, and aging, which is a little bit unusual for an ophthalmology department, but I hope to be able to show you how everything is connected. So there are two main parts to my talk. The first is a little bit about aging in the 21st century, how things are changing from previous generations, and why we should study multiple sensory systems together. And the last part is what I call a tale of two cohorts with apologies to Dickens. It's about how a Wisconsin community is changing how we think about aging in sensory systems because of their longstanding commitment to this research. And so without all of the participants in these studies, I would not be here today. So how do we get old, and how has that changed? So this is one of the favorite things I found on the internet. That is a series of writings from Tahotep, who was a civil servant working for the pharaoh such a long time ago. And he wanted to retire and get his son named to replace him. So nepotism and aging are both old concepts. And so he was writing about the fact that he's getting frail and old, and it's really time for him to retire in order to set the stage for him making this request for his son to take on his duties, so his son would have sufficient funds to support him in his old age. So old age has struck, age has descended, feebleness has arrived, weakness is here again, sleep is upon him in discomfort all day, eyes are grown small, ears deaf, mouth silent, unable to speak, heart emptied, unable to recall yesterday, bones ache his whole length, goodness has turned to evil, all taste is gone, what old age does to people is evil in every way. So a rather depressing view of getting older. No. Some people live to be old in that time period. It's just your risk of dying early was much greater. But because he was well-to-do and a high member of society, he had lived to be rather old and was wanting to make some changes. So this does paint the picture that when we get old, it isn't one thing that is a problem for us. Every system starts to have problems and issues, and we have issues that we're talking a lot about today with depression, with bone problems, with sensory changes, with sleep disorders and being unable to rest in the evening. And so this is still a good summary summary of many of the challenges that older people may face. The good news is it's not the total picture of getting older. Since Tahotep's time, we've learned how to preserve life and live longer. And even in the course of the 20th century, we've seen tremendous advances in longevity. So if you were born in 1900, your average life expectancy would be 49 years of age. But if you were born in 2010, and I can't get that to work, your life expectancy was 78.7. So tremendous advances with our ability to treat and prevent infectious diseases, and our ability to take care of people with chronic conditions has improved. And that's not just across the lifespan. Even at older ages, we've seen increases in life expectancy, so that a person who was 65 in 1900 would expect to have about 12 more years of life. And by 2010, that was almost 20 years longer to live. So we're improving our longevity, but along with that, we want to improve our ability to age well and healthily and not experience all of the problems that Tahotep so eloquently summarized. Today we have this view that not only will we live longer, but we must live healthier, and it's in our control. And so we're bombarded by news reports about how the 60 is the new 40. And to that I say, I'm 60 and I remember 40, and I don't think that's the same. And the things that we should know to do to preserve our health in aging. And even the National Institutes on Aging has programs of exercise and nutritional advice to help us age better as well as longer. And so you start to feel like it's partly something we can do something about. What I'm going to be telling you tonight is a lot of work that's come out of the studies in Beaver Dam. And this study began first as a study of eye diseases by my colleagues, Dr. Ronald and Barbara Klein. They were interested in what are the primary causes of vision loss in aging, and their study was designed to answer these questions and has been an inspiration to scientists throughout the world and made major contributions to our understanding about blinding diseases like macular degeneration. And so this slide is just to summarize a little bit about what they have shown us, which is that people are at high risk of developing macular degeneration as they get older. So if you're 65 to 74 in this cohort study, 20% of the men and almost 30% of the women developed early AMD over a 15-year period. And about 5% developed the late blinding stages of AMD that are shown in the photographs below. They also studied changes in vision and found that about 15 to 20% of people would develop vision impairment, so the inability to see 20/40 with glasses, which can impact on your ability to drive and maintain your independence. Their studies have contributed to our understanding of what are the modifiable risk factors for AMD, as well as identifying genetic markers for the risk of this disease. So we know that this is a combination of both your genetic predisposition and the exposures that we accrue during our lifetime, like smoking and obesity, and perhaps sunlight use and vitamin use might be beneficial. And so it's this kind of work that was being done when here in Wisconsin, and part of the reason that I came here as a young assistant professor was to be able to work with this cohort study and add additional ancillary studies to the cohort. So it's been a tremendous opportunity for me. I'm an epidemiologist, not an ophthalmologist, and so my interests are broad. And when I was looking for a topic for a first grant to apply for, I happened upon a couple of questions the clients had included in their questionnaire that asked people whether or not they thought they had a hearing problem and whether or not they wore a hearing aid. And these two questions formed the basis for the grant application, because I was able to show that there were a lot of people complaining about hearing problems in the cohort, and there were a lot of potential risk factors that were associated with those complaints. So what do I mean about age-related hearing impairment? Like eyes, lots of things can go wrong with ears and auditory systems. But when I'm talking about age-related hearing impairment, I'm talking about a gradual process that's progressive, that's marked by increased hearing thresholds. So things have to be louder to hear them reliably, but also impaired processing of high-frequency or high-pitched sounds. So it becomes harder to hear the voices of little children, to hear the high-pitched sounds on your stereo, and mostly the biggest complaint is difficulty understanding speech. And those symptoms are that when you're in background noise, like at a party, it's hard to, or a restaurant, it's hard to hear what people are saying, that it's difficult to hear consonant sounds correctly. So you might begin to miscommunicate with your loved ones because you hear words differently than what was said because the consonants become hard to recognize. And I usually show a cartoon that I don't have copyright privileges to. So I left that out today, but it's a cartoon written by Larson that showed this painter working on a painting, and a page comes in from the king and asks how he's coming with his painting of St. George and the Dragon, and the artist looks appalled because his painting is of St. George and the Wagon. He misunderstood what the king wanted. So frequently you notice you're having hearing problems because you start complaining that everybody else is mumbling. And so that's a clear characteristic of not hearing what other people are saying. And your relatives start telling you you're turning the volume on your TV up too high. And so perhaps your neighbors are complaining as well. How is it diagnosed? By patient history examination and audiometry, where you hear different sounds under headphones to map the kind of loss that you're experiencing. And most often it's treated by a combination of rehabilitation, counseling, and the use of devices, which can vary from the classic hearing aid that you're all thinking about to also devices that just amplify that TV sound if that's where you're struggling, or devices that might be used in your church or in an auditorium, depending on where you're experiencing communication difficulties. Well, why study ears and eyes together? It's not just that it was convenient and cost-effective, which were the arguments I made to NIH, but that they share some similarities. So they're both sensory organs where the eye and the ear are where signals, the waves, either light waves or sound waves, are transformed from that wave that stimulates the organ to a neural signal that goes to the brain where it's interpreted. So we don't see with our eye and we don't hear in our ear, we see and hear in our brain. And so these systems can tell us a lot about each other because the things that affect them may be quite similar. And our hypothesis has long been that not only do they share a brain, but they share a body. And if you take a person perspective, we tend to not do things that just affect our eyes or our ears or our brains, but our whole body is affected. And so our hypothesis was that we could look at factors that are circulating, like your cholesterol level and your cigarette smoking, the toxins from that might be affecting all parts of your sensory systems and your cognitive function as you age. And so we can gain some efficiencies in cost by sharing costs across grants, but more importantly, we can learn about what's happening in the neurons in our brains by studying these systems collectively. My ideas are not new. What was an inspiration for this work was some papers I came across by this otolaryngologist, Sam Rosen, who was quite an interesting character who went around the world doing some early studies of hearing as he taught his surgical techniques to different practitioners in different countries. He tended to go to third world countries to share his knowledge and even provide tools to be able to solve hearing problems in lots of places around the world. And he used those relationships to do these very early epidemiological studies. But his idea was that anything that impairs the blood supply of the cochlea, the inner ear where this signal is changed to a neural impulse, is likely to affect the efficiency of the inner ear. High-frequency hearing loss may be the earliest indications of the beginnings of degeneration of the vascular system. So things that affect vascular health might be affecting hearing, and perhaps early changes in hearing can be a warning sign of vascular changes which back in the 70s we could not easily detect. He did studies in Africa of a rural tribe that didn't have much noise exposure and found that their hearing was preserved in aging compared to people in the United States, and thought this might reflect the fact that they were very physically active, did not smoke, ate diets high in fruits and fibers, had very little hypertension, and they were not obese. He followed that up with studies around the world comparing rates of hearing loss in people who had high and low risk of cardiovascular disease, and that supported his ideas. And he even participated in an ancillary study of a diet trial to try to show that hearing changed with cholesterol and fat. But these were early studies, and they're all limited and flawed, and so it left plenty of room for those of us who came later to be inspired by his work. I'm often asked, why do these cohort studies? It takes a very long time to get answers. As Terry said, I've been here working at this for quite a few years, but we are beginning to get some answers that I'll share with you tonight. Well, often it's because we want to know about regular people, the general population, rather than just patient populations. If you're studying a disease which brings people into the doctor, it's easy to use that as the group of people that you're studying. But for some changes, like vision changes and hearing changes, you may not be aware that you're experiencing problems. And so the people who come into the doctor tend to have the worst cases. And that's important to not draw conclusions from comparing the extremes, but to think about, from a public health perspective, what can we do as a society to reduce the risk for the average person. And then, because I'm an epidemiologist, what we like to do is measure everything about everybody when they're well and healthy, and then follow them until they have health problems develop. So we can use statistical modeling to say what was different about the people before they got sick that was associated with getting sick later. So in this example, I think, perhaps you have, if you're following this healthy population, maybe some part of that group smokes, and you want to know, how is it more likely that smokers develop a health problem later? And this is the kind of questions that we ask in our studies. So here's my tale of two cohorts. As Terry told you, there's two groups of people we've been following in Beaver Dam since the Kleins started their studies in the late 1980s. But what the Kleins did was do a private census. So just like the U.S. Census asked everyone to identify everybody in their household, they did a private census to ask who lived in every dwelling in Beaver Dam and identified every single person who was 43 to 84 years of age in 1987 when the census was done. They then invited them to participate in the Beaver Dam Eye Study, and it was the people who did that first examination that I invited in 1993 to be part of the hearing study. And there were 3,753 incredibly wonderful people who gave me 90 minutes of their time for no compensation and have been followed every 5 years since then. They're still coming back. This year we finished our 15-year follow-up, and is that right? I do the math. 21-year follow-up. I knew I got that wrong. Our oldest participant is now 102 years of age. So they're amazing people who have been very generous over all these years. The offspring study we started in 2005 to find out what's happening to the next generation. We knew from the studies in the first population about people who were born in the first half of the 20th century. But being a baby boomer and being rather self-absorbed like we all are, I wanted to know what my future held. And so we started to find out whether health is improving as we age as baby boomers compared to our parents and our grandparents. And by studying people genetically related, we know that we've got very similar people genetically. What's changing is lifestyle, behavior, environment, where we live, how we live. And so it would give us some clues about things that we might modify and change to improve public health. And we had 33 2,300 wonderful offspring who came from all around the world. They didn't necessarily ever live in Beaver Dam. Their parents did. And people had moved away, although fortunately being Wisconsin, 75% stayed in the area. We had people come back from Australia and from other parts of Europe, and people who let us know when they're having family reunions, so they come in for their examinations. And they've just been tremendous. And we're now doing our third visit with this group of people, and we'll finish that data collection next year. We see people in a suite of offices adjacent to the hospital in Beaver Dam. So the Beaver Dam Community Hospital has been a great supporter of these studies and enabling our research by helping us locate and develop our space. To tell you a little bit about these incredible people, they were 66 at baseline in the EHLS and 49 in BOSS. And as you can see, their birth years span the majority of the 20th century when you combine the two groups. And so that will be something we come back to later in the talk. Slightly fewer men than women, which is not unusual in aging studies because as we get older, women are around a lot longer than men. And you can see the dramatic difference in education level, where 30% had some college education in the first cohort, and that's 70% of the offspring now, representing the tremendous opportunities that were afforded baby boomers and beyond. Smoking rates are lower for ex-smokers and current smokers combined. The smoking has gone down, although there's still quite a few people smoking in the offspring cohort. So what have we learned about hearing? Well, we've learned that like eye diseases and vision impairment, the risk increases with age. And putting the data together for both cohorts, you can see that the risk is low of developing a hearing impairment until you're about in your 60s, when about 20% of us will develop a hearing problem in the next 5 years, men more than women. And it increases as you get older. So even if you're lucky enough to hang on to your good hearing until you're 80 years of age, that doesn't mean you're going to keep it. You continue to be at risk of developing hearing problems, which might mean that it's a normal part of aging, but perhaps not. The prevalence of hearing impairment goes up because we don't die from hearing loss. It's something we live with. And so as we get older, not only are more people affected by hearing loss, but their hearing is worse. And so they have greater degrees of difficulty in managing that hearing loss. What have we learned about how we might prevent it? Well, we're beginning to get some insights. No one set of studies will give us enough information to demonstrate that we can definitely prevent things, but this is the first set of studies that is indicating there might be something we can do about hearing to preserve it as we age. So in EHLS, we've been able to show that not only is education, which is a well-known risk factor for other chronic diseases, people with less education are more likely to get heart disease, more likely to have lung problems, more likely to die early, more likely to develop dementia. They're also more likely to have hearing impairment. But also smoking, central adiposity, which I'll make myself stand up, is that central part. Your waist circumference is a good indicator of obesity, and people with larger waists are more likely to develop hearing loss than smaller waists. Poor glycemic control refers to diabetes. If you have poorly controlled diabetes, you're more likely to develop a hearing impairment over the follow-up period. And people who have high levels of inflammatory markers, these are biomarkers that we can measure in the blood that aren't indicating acute infection, but that are at the high end of normal, suggest that there's some inflammatory process going on that's contributing to aging losses. And these are well-known risk factors for heart disease and are emerging risk factors for cognitive impairment and dementias. In the offspring study, Dr. Mary Fisher and our group recently published our follow-up paper that showed that not only the older you are and being male are bad and having less education is bad, but obesity with a different measure and atherosclerosis. So we measure with carotid ultrasound the thickness of the arteries and the presence of plaque, which are signs of vessel changes associated with risk of heart disease and stroke, was also associated with an increased risk of developing a hearing impairment in the follow-up period. So what does this tell us altogether? Well, this slide is trying to illustrate that by showing you under that group labeled A that if you didn't have the risk factors, if you had a college education, you were thinner for Beaver Dam, never smoked, and did not have high glycemia, that you would be, the likelihood of developing hearing impairment in 15 years would be about 47% if you were a man and 27% if you were a woman. But if you had all of those risk factors that I mentioned, your risk goes up to 93% and 73%. So this is a dramatic difference that suggests that healthy lifestyle and good control of diabetes can help us reduce the risk of having hearing impairment. But more importantly, we wanted to know, as I said, does it matter when you were born? And the Kleins had shown that for macular degeneration, people who were born later in the 20th century up through the war period were less likely to develop macular degeneration in their study. And so we wanted to extend that to the offspring and the baby boomers and the Gen Xers, and that's shown on the left-hand side of the slide, where you can see this trend of decreasing risk of developing macular degeneration for the silent generation compared to the greatest generation, and for those born in the baby boom period, and again for those who are Gen Xers. And so we have this improvement in the health of aging people depending on what time period you lived through. And we see the same thing for hearing impairment, where the risk is declining rapidly. That suggests these are modifiable conditions and not just genetic disorders, because genes don't change that quickly across time. And so it's suggesting that something about the way we live, the exposures that we have, may be contributing to our risk of disease. Well, what changed in the 20th century? Just about everything. So pinning it down to what is the cause of this improvement in health will be very difficult. There's been a change from having infectious diseases as a major cause of death to chronic diseases like heart disease. We've had a number of discoveries that led us to introduce antibiotics and vaccines that reduce childhood infections. We have Clean Air and Clean Water Acts, and in workplaces, new laws to reduce the noise exposure that people have. And then we had the great events of the 20th century, where some people lived through depressions and wars, and others were unaffected by such catastrophic events. So all of these things may be contributing to not only our improvements in longevity, but our improvements in health as we age. We know smoking rates have gone down, cholesterol levels are down, blood pressure levels are down due to treatment, but not all the changes across the 20th century have been good. Obesity rates are up. Sedentary lifestyles are much more common as we move to our connected lifestyles, but decrease in noisy jobs, and noise can be damaging to the cochlea. Tuesday, I learned about this paper by Jones and Green at a part of a workshop that was being held in Washington, D.C. about how to prevent Alzheimer's disease and other dementias. And they were reviewing in this paper why there's been such a decline in cardiovascular disease since the early 1970s. The rates have been going down. And why we're now seeing a decline in the risk of dementia and Alzheimer's disease. And what they said was that the burden of disease of the 20th century, like the 19th when we died from infectious diseases, was not an inevitable fact of life, but a product of lives lived amid specific and malleable conditions. And so there are many people thinking that these improvements in health in the latter part of the 20th and the first part of the 21st century are because there are things about the way we live that we can change to continue to benefit and improve the health of future generations. So our patterns for hearing loss, our patterns for eye diseases, for vision impairment, are mirroring the things we have been seeing for cardiovascular disease, and perhaps reflecting those shared risk factors that person is exposed to that's affecting more than one organ system. It's also possible that early life is very important. It's not just your life in your 50s, 60s, 70s that impacts what happens to you as you get older, but what happened to you from birth. And this is a fascinating study that I came across that had been done in England that looked at people who were born in the 1920s and followed them up when they were 68 years old, and found that the kids who had had lower weight at age 1, which they viewed as an indicator of a less healthy start in life, a smaller child, had worse lens opacities, worse hearing thresholds, weaker grip strength, a sign of your ability to manage physical tasks, and that was independent of age, sex, social class, and height. So there's some growing suggestion that your entire life helps determine where you end up as an older adult. And so we think this is our data are fitting with this idea and something to continue to investigate. We're also interested in the incidence of cognitive impairment and how it's related to these sensory changes. And so this slide just shows that, yes, cognitive impairment is an age-related condition. And Dr. Fisher has recently published a work that says, well, can we predict who develops cognitive impairment in this cohort by looking at who had vision impairment, who had hearing impairment, who had olfactory impairment, the inability to identify odors. And all of those sensory changes were predictors of who developed cognitive impairment. But for those of us with these disorders, there's good news, which is it's not a one-to-one relationship. This PPV refers to a positive predictive value, which says that if you have all of these conditions, what's the likelihood you're properly classified as ending up with cognitive impairment? And only 40% of the people developed cognitive impairment, 60% remained healthy. So it's okay to have these impairments. You're not necessarily becoming demented. But if you had none of these conditions, 93% of the people remained unimpaired cognitively. And so if you're doing well on all of your sensory systems, you're doing well with your brain as well, which makes a lot of sense to us because they share that central processing. In the offspring study, we use a slightly different measure of contrast sensitivity to think about vision. And this is an aspect of vision that's important for seeing in low light conditions, like driving at night and walking on stairs. And even there's a study showing that it's important in managing your pill boxes because you have to identify all those tiny pills in those tiny boxes. And we measure this with a chart called the Pelle-Robson test, which is shown in this slide. And work being done by Carla Schubert in our group with the offspring data, where we have a comprehensive battery of cognitive function because they're much too young to have cognitive impairment, is showing the same kinds of relationships where people with poorer vision, poor hearing, poor olfaction were less likely to have good cognitive function 5 years later. And so they had greater declines in their cognition than people who had good sensory systems. So we're now using all of this information to create a new metric for healthy aging that focuses on brain function, using data about your sensory systems, data about your cognitive function together. And again, this is Dr. Fisher's work, and this is preliminary analysis. She's still working on the manuscript that shows that people at higher educations who have never smoked, never had heavy drinking, which we think of as 4 or more drinks a day, because this is Wisconsin, and who exercise somewhat, not high levels of activity, but some activity, we're all more likely to have healthy brain aging in our cohort. And so we're very excited that this approach will help us measure the combined impact of lifestyle changes that may have on many aspects of our health and aging. But we still have questions to answer. How do these changes, are they markers of the neurodegeneration in the brain? We have this idea that they are a marker of neural change, but we're going to use new technology called OCT imaging in the eye to where we can measure the layer that is the ganglion cells in the eye and use that as a marker of ganglion cells throughout the brain. So that's some of the innovative work we're doing, combining our interests in eyes with our other interests in aging problems. And although we're seeing these associations, we're a long way from proving that they cause, that atherosclerosis and inflammation cause the changes. And so we're using some analyses that are of genetic markers for these risk factors to add to the evidence that they are causing the problems in sensory systems and cognitive function. And ultimately, we want to answer what can we do to increase our chances of healthy brain aging. So why study multiple systems together? It's because the same things that are good for your heart may also be good for your eyes, your ears, and your brains. Or as our mother said, go to school, get a good education, don't smoke, shut that TV off and go outside and play, eat your vegetables, and get a good night's sleep. Those things that were so important for good, healthy children and having a good start in life may be important throughout the lifespan and help us not only live longer but live better for many more years, maintaining our independence. But we're a long way from answering that with convincing scientific evidence, but our results are quite promising that we're headed in the right direction. And it's really that long-term commitment, both from the community of Beaver Dam, the participants in the Beaver Dam Eye Study and EHLS, and their offspring who have been so willing to be part of the BOSS study, that is partnering with us to help us understand how to prevent or delay age-related health problems. And so I'd like to close by just acknowledging these remarkable people who for all these years have been coming in every 5 years to have these lengthy exams, one of which was 4 hours for the offspring at the baseline. And they've received very little compensation over the years. Every once in a while, NIH lets us give them $50, but not usually. The community has been a booster for this study, even with the Lions Club providing rides for people to get to the visits as they get older and they're not driving. They've been volunteering for that. I have a large list of collaborators, both here at the university and at universities around the world. One of our statisticians is in Taiwan. People have been remarkable about participating in these studies. We've been fortunate to work with many wonderful students, training them, and of course the remarkable staff that do the actual daily work of this study. And of course our funding from both the National Institutes on Health, the Research to Prevent Blindness, and the department, which has helped keep these studies going all these years. Thank you.
Thank you, Karen. Hi, my name is Gillian Fink, and I'm going to facilitate a couple of questions, if you have any, for Dr. Cruickshanks, Dr. Young, other physicians here. And then we're going to have somebody share a closing remarks. We have a grateful patient here today, and then Dr. Young will give us the farewell and see you in April for stem cells. So who has a question? And I'll come to you with I'll be 2 people at once.
I'm rather curious because the youth of today, there's the computer and constantly use of a computer, number one. Hearing, you have these jam sessions or whatever. The loudest that you, and I often wonder about drummers, whether they have ear problems after their professional life. There are all of these things that seem to me to suggest that you're going backwards rather than forwards. And people prior to the 1920s maybe have lived a healthier life than we have today because we have so many synthetic foods, et cetera, et cetera, et cetera.
Right. There are many changes that are good and bad. And so there are data from studies of musicians that professional musicians are more likely to have hearing problems, but we don't know if the volume that's so annoying when my kids listen to their musical devices is sufficient to cause damage to the ear. It has to be very, very loud, like you would get in a workplace. And so we don't know whether things will turn around. But that's part of why we're studying younger and younger people, to be able to understand that. And now see, this is my memory thing. You had 3 parts, and I remembered one of them. So I do think that it remains to be determined whether health will continue to get better. And while people in the first part of the century, in the 20th century, may have had a healthier lifestyle, being closer to growing their own food and having fresh food, there have been improvements in the availability of fresh food to people living in cities. And Beaver Dam is a city as well as a rural area. And so there may be some improvements that have, with the refrigeration and processing of foods, have made them more widely available.
Maybe I missed it, but did you take into effect the occupations?
Yes. Yes. We found that people in certain classifications that would be more blue-collar factory workers and people in industries were more likely to have hearing problems develop, but it wasn't related to the noise because, of course, not everybody in those occupations is noise exposed. So we asked a detailed noise history. And while that might affect your hearing in midlife, when you start with older people who have good hearing, it doesn't seem to influence their risk of developing hearing problems later. So once the noise stops, the harm seems to stop as well. But that's very controversial. I get a lot of feedback about that position at national meetings because there's some mouse models that would disagree with what I just said.
I'm interested in the vision side, and you were talking about macular degeneration, but what about other things like glaucoma, and I don't know the names of some of the other diseases, but I have several different eye diseases in my family, and I'm an artist, so I'm really concerned about that.
And many eye diseases do have a genetic component, so it's good to then consult with your ophthalmologist about your personal risk, given your family history. Yeah, and the Klein studies do talk about, they have done research on glaucoma and cataract, which of course is a leading cause of blindness too, prior to cataract surgery becoming so readily available in this country. Yeah. Can I ask you some follow-up to that? Maybe I can
you assume then that some of the improvements that you've been seeing over the years in macular degeneration that would also then apply to glaucoma or other?
We see the same type of thing for vision and for cataracts, but I'm not aware of the fact that we've done those analyses for glaucoma, so I can't speak to that.
Okay, I think we're going to switch to Ellen Geischert. If we come to the podium and we'll put a lavalier mic on you.
But we'll be available.
But we'll be available. The experts will be available afterwards down front here if you want to ask some questions. Also, I'll be sending out an email after this. You can get in touch. You can join our new mailing list. And what else can you do? Oh, I know. I'm going to share a video of this with you. You can send it to people who might be interested in learning more as well. So, Ellen, are you testing your sound on?
Can I set this?
Yeah, you're great. You can set it down. Yep.
Can you hear me? Okay. Good evening. I'm very honored to be here with you this evening and share my story with you. And I want to thank Gillian for giving me this opportunity. This type of speaking is still a little bit new for me, so please bear with me if I sound a little bit nervous, because I am a little bit. I'd like to tell you about my background before I get into the meat of what I want to say. I'm the firstborn of 7 children. As a very young child, I was diagnosed with rheumatic fever and treated and hospitalized with it off and on for a period of 5 to 6 years. Some of you may not have heard of rheumatic fever or don't know what it is. It's an inflammatory disease that is caused by group A strep, most commonly known as strep throat. It can affect the heart, the joints, the skin, and nervous system. You hardly ever hear about rheumatic fever these days because of the great discovery of the antibiotic penicillin. I tell you about this childhood illness because I believe it played a large part in my decision to become a nurse when I grew up, so that I could help others. I retired in April of 2014 after 44 years of nursing, having worked in pediatrics, the ER for 30 years on the night shift, and then ending my career in the PACU, which is also known as the recovery room. I had cataract surgery in my left eye in 1988, and because of an unforeseen event that occurred at that time, I have had ongoing problems with my left eye that has required 6 additional surgeries. One of them being for a detached retina and 3 separate corneal transplants. The first one being in 2001. I had my 3rd corneal transplant in July of 2015. Within a couple days of that last surgery, I developed a very serious and uncommon infection in the inside of the eye called endophthalmitis. That experience is what has really brought me here before you today. Because of the weekend shared ophthalmology on-call system, I was seen and treated on that Saturday and Sunday here at the UW by Dr. Nork, who's a retina specialist, his retina fellow, an ophthalmology resident, and a medical student. On Monday, I returned to my clinic, which is the Davis Stewart Dean Clinic, for ongoing care that I continued to need. Turns out that the retina doctor from Davis Stewart Dean who continued my care and treatment had been a retina fellow under Dr. Nork. So that kind of made me feel extra good, I guess you would say. Weeks later, when I was doing much better, I wrote a thank you note to Dr. Nork and his team. Because of my high stress level during that time, I wasn't so certain that I had really conveyed my gratitude to them. And having been a practicing nurse for 44 years, I knew how important and special it was to have someone say thank you for all you did for me. As a result of my thank you note, I have met Gillian, who's the director of ophthalmology, or who's the development director for the ophthalmology department. I have toured one of the eye resource labs here at UW, met 2 of the eye research scientists, and learned of their exciting work. And I've had the privilege to meet Dr. Terry Young. Also, I have met a few of the staff from the UW organ transplant and tissue programs, met a few of the Wisconsin IBank staff, and learned about the corneal transplant program and process. Earlier this year, I committed to being available to the IBank staff in their outreach programs. I have to say that I was really blown away to find out that the UW Ophthalmology Research Department is like 2nd or 3rd only to Johns Hopkins here in the United States for the eye research that they do. Some of their research, at least a few months back, was focused on retina cells and glaucoma, which is very applicable to my situation. Before I begin my closing comments, I want to also let you know that I have a fabulous cornea specialist in Dr. Croasdale, who practices at Davis Stewart Dean. He has also served as a member of the UW volunteer faculty for more than 15 years. Dr. Croasdale has been on this eye journey with me for 16 years, and I think the world of him. My endophthalmitis experience was very stressful and frightening, and being a nurse only added to that level. It's like you know a little but not a lot, and so you worry more. But all of this has turned into something very positive and has given me an excitement in my heart and soul to do what I can for the IBank, corneal transplants, and to be supportive to the UW Ophthalmology and Visual Science programs, both monetarily and non-monetarily. I'm not here to ask you for money or pat myself on the back for what I'm doing. From the bottom of my heart, I'm just sharing with you my story and journey in the world of sight, letting you know that there is great research being done here at the UW in the Ophthalmology and Visual Science Department, and that we have fabulous people in our midst making tremendous progress as they work to improve our vision possibilities. And finally, I'm saying thank you to the remarkable care that I received here. Thank you. Do I just click this?
Okay. Well, thank you so much, Ellen. It takes a village to do all kinds of work, and I just wanted to take this opportunity to thank the engines that made this train run. Gillian Fink, our Director of Development, Chris Geyer, who is in the back of the room doing IT, Jessica Arendas, who is our Director of Marketing, Nicole Hyman, who is outside manning or womaning the table, Jennifer Preby, who is also womaning the table. I'd also like to thank the Lions, in particular Rick Deluge, who runs the IBank, and to all of you for coming tonight. Thank you very much. And on Wisconsin. Thank you.